Hey, everybody, John Marshall for Oncology Unscripted. And this session is all about a big problem that I hate. It's changed my clinic. I really don't like anything about it. It is not what I signed up for. It is young people getting GI cancers. And, the deal is that they were all supposed to be 60, 70, 80 years old with colon cancer. And now close to half of my clinic is under the age of 50. And it's a totally different impact, a totally different disease. And there was a recent JAMA paper, which we are featuring, about the statistics around not just colorectal cancer, but all GI cancers showing an increase. And I am lucky enough to have as one of those young patients, Chad Leo, who has taught me as much about this whole thing as I've taught him about the management of this. And he was first diagnosed when he was age 42, and it was out of the blue. And so first, Chad, thank you for your willingness to jump onto this risky venture of Oncology Unscripted. Tell us a little bit about yourself and how they first found it, and the sort of out of the blue, something on your list that was never on your list before.
Well, first, let me say, Dr. Marshall, thank you very much for having me on here. Through this entire journey, I'm just overly grateful to be able to kind of give back and share my experience in the hopes that maybe it'll help other people my age, and unfortunately people even younger than me that are being diagnosed with colon cancer. So when I was first diagnosed, I was going through some severe abdominal pains, and I later found out that was sort of similar to the symptoms that other people that were diagnosed with colon cancer were going through as well. And I was reluctant to really get it looked at. And as time went on, the symptoms progressed. And finally, I was convinced to go to the ER. And, I think the way that doctors first saw me, they go, he's 42. There's no way that this could be anything that severe. And it was almost a detriment to the point where I wasn't fully examined to the extent of what should have been part of like the just all the checkoffs that probably should have been done.
So what did they think it was? They just like constipation or something else?
Yeah, their initial thought was it's probably just like Crohn's disease or some type of colitis. And so that was it in my head. I was like, okay, that's probably what it is. And then a month later, I'm back in the ER again, and then the scans indicated that there was in fact a mass in my large intestine.
Well, so, when I went to medical school 1,000 years ago, you probably weren't even born, is that, we were taught that only older people got colon cancer, so it shouldn't even be something we look at. There has been a growing message of young people getting the disease, but there are a lot of folks who it's just not on their checkoff list. And so the patient doesn't know to ask about it. The physicians are saying that can't be that, as you just said. To your knowledge, did you have any known risk factors? I mean, your family or, your other medical issues or anything that would have teed you up for colon cancer?
No, nothing would have indicated that, especially in my family history. There were some bouts of, I think I had a grandfather who had bladder cancer. My paternal grandmother, she had ovarian cancer, but nothing along the lines of colon cancer. It wasn't on my radar. It wasn't anything where I was, kind of directed where I should start getting screened early.
Yeah. Well, one of the reasons why I'm asking is that this paper that we're featuring does list the sort of standard risk factors. We got to look out for those people. Well, those people are kind of being followed, or they should be already, because they're in that risk factor category. But most of my patients are more like you, where it just out of the blue, very fit, obviously, otherwise very healthy, out of the blue with a diagnosis of colon cancer. So message heard loud and clear that we're sending out to the medical community with this discussion. Tell me what it was like to out of the blue at 42 years old, how all of a sudden have colon cancer, surgery, chemo. How disruptive was all of that on things?
It was a huge disruption. So my job I'm a detective with the DC Police Department. So it was a huge impact as far as, my job requires me to be very active. And so going through the treatments, would mean that I would have to sort of take a break. And I planned essentially to use my sick leave as much as possible just so I could focus on getting better. All of these thoughts start going through your head at 42, and I was single then, and you start kind of thinking, what have I done? What have I accomplished with my life? That plays a heavy toll on your psyche, and also in some regards too, I think kind of being on a little bit further removed from some of this, I think it also pushed me to really take a look at my life and really not take anything for granted.
Yeah. I would rather you not have to have had life stress to do that, but I read loud and clear.
Neither would I, but I mean, I guess you got to take everything with a grain of salt. There's always a silver lining to something, and I think that sort of mindset just kind of kept me going and just being helpful. I think obviously having a terrific care team such as yourself and the team that you had with you made a huge impact. I think just where I felt like I was, my best interest was at heart.
Yeah. And did you tell the gang at work? Did they make accommodations? Did people try and help you? Or did you feel like you wanted to keep it quiet?
I basically told my close friends and obviously my supervisors what was going on, and pretty much everybody from work were super supportive and would reach out or come visit, and just every once in a while send encouraging messages. And I couldn't have asked for a better support system.
Yeah. So you went through surgery, did some chemotherapy. We were in follow-up. You've been getting the fancy ctDNA test as well as scans. Describe a little bit about that, because you've had a roller coaster there too.
It was. I mean, so the initial surgery that I had was basically to remove the mass, and then I was affixed with a colostomy bag, and no pun intended. I don't know if we're allowed to curse on the podcast, but I won't. Oh, okay, I'm getting a thumbs up. So, pun intended. It was a very shitty situation, and that was a huge adjustment where not only did I have a colostomy bag, but I had to learn how to do daily activities with that, and just the sheer embarrassment of just looking at myself in the mirror with this stoma poking out of my stomach. You still want to go out, you still want to try to be somewhat normal, but then you had this colostomy bag, and I can remember at times meeting up with people, and you start to smell something and you're like, I gotta go. It's like a leak or something. And, so I would like limit my exposure with my friends or whatever to a few hours, just because I just didn't know what could happen. Once we got to a point where I was essentially no evidence of disease, I think I was kind of encouraging or pushing you to like, hey, well, maybe we can look into getting this resection surgery. So that was good to get to that point. And then the follow-up tests and the blood tests post that, I think just kind of set up a platform, if you will, of like, okay, let's keep on banging out whatever the next steps are.
Yeah. Yeah. I know we talked about the role of exercise. One of the big studies that we featured in a previous episode was the dramatic impact that having a personal trainer had. I don't know if I've shared this with you yet, but half the patients got a pamphlet that said go exercise, and the other half were assigned a personal trainer. And there was actually a survival delta between those. You're already very active, but now that when you talk about the ostomy, if we're recommending exercise, and ostomy is exactly counter to that. It makes it very, very difficult to do the kind of physical activity that I know you like to do.
Yeah, that was so. I had started an intense workout routine before I even got diagnosed. So to have the ostomy, I basically my exercise routine just kind of consisted of lots of walking, maybe some push-ups, and I tried hard not to do anything that would disrupt where the ostomy was or where the bag was, just because I was so self-conscious of something. So I didn't even want to go to the gym. I didn't want to deal with the embarrassment of people seeing the colostomy bag. I think overall, I mean, I think I felt it was just important just to stay active and move no matter what it was.
Yeah. You're a few years out now. With each new scan, with each negative blood test, we're a little bit further off, where we're going to be all right. And fingers crossed. I know we've had some nervous times still. You've got an audience of docs right now, all around the country, all around the world, other people in the industry. What sort of message would you like to share, given your experience? Is there anything you'd like us to hear about?
I think most importantly, and you do a great job of this, it's giving your patients hope and giving someone like myself hope, even through the early stages where you feel like everything is at a loss. The way that you would basically, hey, look, these are the steps that we're going to take to try to get you to a point where you can hopefully live as much of a normal life as possible. And I think that's one of the key things. Because if you have hope in your mind, who knows the benefits that's going to provide the rest of your body, where your body may like just continue to keep on fighting, and despite the chemo treatments, or even like the subsequent blood tests and scans that we go through afterwards, you still cling on to that hope, even though you get a little bit of an anxiety every time that blood test or scan comes up. Like I mentioned before, I know that I'm in good hands, and that if something does come up, we'll be able to treat it as early as possible and just give myself just a better chance of, again, I think everybody, or at least from my own personal experiences, to try to live your life as normal as possible after going through an experience like that. And you and your team has afforded me that ability.
We're happy to do it. And there are a lot of people out there who can do it well too. One of the things that was fairly new when you were getting your chemo a few years ago was 3 months versus 6 months of chemotherapy. And, at a young age, you have a physical job. You need to be able to use your hands. The reason for 3 months versus 6 months was the cumulative neuropathy of oxaliplatin. And so we had those discussions about that. There are a lot of docs out there who might be listening in who, as a young guy, you can take it because you're young and pushing you to the 6 months. But right now, one thing I'm glad about is your scans you're good, and no neuropathy or limited neuropathy.
None that I can detect. And I
And
know
you're a detective.
Yes, and I got to do a lot of typing too. So it's important that everything works, at least where I can type.
Yeah.
But yeah, I remember there was a point where I started feeling some neuropathy in my hands, and so like subsequently, whatever happened after that, it is now since subsided.
Chad, thank you so much for taking some time to discuss this with us. We all hate this trend. It's why there's a big important paper on this, and you are the real kind of person who's being affected by this. And for you to share all of this with us means a lot to us and teaches us, as I said at the opening, maybe more lessons than we've ever taught you. So, Chad Leo, thank you very much for joining me on Oncology Unscripted.
Thank you so much, Dr. Marshall. It's my pleasure.
Hey, everybody, John Marshall for Oncology Unscripted. And I promise there is no script anywhere in front of us right now. And as you know, what we are focusing on this edition is that why are young people getting cancer all of a sudden? I thought we were supposed to be getting healthier. We just blew up the EPA earlier this week. So I guess we're all going to die of cancer sooner than later, if that's all works out to be true. But even before we blew up the EPA, some very, very smart people have been watching and monitoring this increase in young people getting colorectal cancer and other GI cancers. And I am honored to be joined by the lead author of a very, very important review paper that looks at this that's been going on all around the world and in the United States. Thejas Jayakrishnan has just joined me today from the Mecca of all knowledge. That would be Boston at the Dana-Farber. So thank you very much for joining us, and maybe give us a little bit of an introduction and maybe a little bit about what drove you to put together this paper.
Absolutely. Thank you very much for the kind introduction. I am a gastrointestinal medical oncologist at Dana-Farber Cancer Institute, an instructor of medicine at Harvard Medical School and Brigham and Women's Hospital. And I work closely with the Dana-Farber Young Onset Colorectal Cancer Center. I do predominantly like clinical research and also like translational work, trying to identify what are the biomarkers or molecular characteristics associated with young onset GI cancers. And I finished my fellowship in Cleveland Clinic, and I had wonderful mentorship there with Dr. Khurana. And I spent a lot of time during my fellowship trying to understand these molecular characteristics of young onset GI cancer. And it's mainly during the fellowship that I noticed there's increasing incidence. And really, the mentorship was helpful to kind of getting me more attuned and recognizing those aspects, and also realizing some of the unique characteristics of this population. So that led me to like involve in research related to microbiome, metabolomics, trying to integrate different aspects of early onset GI cancers.
I'm an old oncologist, right? And so I didn't sign up for a lot of my clinic being 20, 30, and 40-year-olds. Back then, they were all what we later found out to be Lynch syndrome patients and had genetic inherited syndromes, et cetera. Nowadays, that's not who all of these people are. And they are, very fit, very healthy, no real strong risk factors that are showing up. And I think early on, people like the American Cancer Society and others were saying, oh, that's just because they have bad behaviors, or, they have the wrong parents, or something was causing it. And I noticed that in your all's review, those things were mentioned again, but also to your acknowledgement just now, is that we still really haven't uncovered what the heck's going on. Let me ask specifically, because I did a lot of work with our molecular database. We could not really find any clear, next gen sequence differences based on age. Have you guys got any more insight into the genetic piece of this?
Yeah, I mean, you're very right, Dr. Marshall. Like, so, yeah, genomically, we do not see a huge like difference in like early versus average onset. Certainly, there's a higher prevalence of germline predisposing syndromes in younger people, but that doesn't explain the increasing incidence over time. Vast majority of these cancers are sporadic, meaning it's not inherited type syndromes. We do see there are certain subsets of early onset GI cancers. For instance, early onset cholangiocarcinoma, there's a higher risk, higher prevalence of FGFR2 fusion that has been described, and which is a targetable mutation in cholangiocarcinoma. In pancreatic cancers, there's a higher prevalence of not having the KRAS mutation in early cancers, but having other targetable mutations like IDH1, but again, not as standard targeted therapy in pancreatic cancer. These are still like very small percentages. So what we really see is also the fact that most patients with young onset GI cancers do present with more of an aggressive disease. There's a higher prevalence of, say, signet cell cancers or poorly differentiated cancers across the different early onset GI cancers. A lot of patients present with stage 4 disease at diagnosis, which could be partly from any delays in diagnosis. But then we do see higher prevalences of these aggressive variants. And the fact that even with aggressive treatments, younger people, you can imagine that, most of them do not have a lot of comorbidities that may prevent them from getting intensive treatments. Despite intensive treatments, we do not see a proportionate improvement in the outcomes. So there's definitely more molecular factors that are interplay, which need to be understood better.
Yeah. So bad cancers, not necessarily better cancers. Yes, they're younger. You can beat them up more, but that doesn't necessarily mean it's translating into improved outcomes for those patients. Let's sort of talk a little bit about the current theories as to why. One of the things that only recently, last 3-5 years, that I recognized is that for colon, and that's not necessarily the other GI cancers, Instead of the normal sort of 40% right, 60% left,
Mhm.
we're seeing this very high percentage of rectosigmoid tumors. And so
Mhm.
I've been sort of thinking this must be some sort of microbiome. I hope it's not Starbucks, and I hope it's not bourbon, because then I'm just going to get it too, because those are like my two favorite things. But so there's some people looking at exercise or antibiotic use or other kinds of components. Microplastics people are out there.
Absolutely.
If you had to put a quarter down right now and bet, what do you think the
Mhm.
common sort of theme or molecular pathway that's causing this? What would you say?
I think it is an interaction between the environmental factors and the microbiome. And that's what, a lot of our studies are trying to do, like a deconvolution, kind of like understand how much one component is contributing. We definitely have increase in obesity over the last, 40 years. So there's childhood obesity is increasing, and it has been shown that early like exposure to like adults in obesity or even maternal obesities can be a risk factor for early onset GI cancers. But you're right, I do see a lot of people who do not have these risk factors. So there has to be other factors also. Physical activity do correlate. Lower levels of physical activity has association with higher risk for these type of cancers. But then again, we see people who are, athletes who do develop these early onset GI cancers. I do think that the exposures do play a role, because the dietary patterns have changed over time. We do see associations with Western style dietary patterns, which is like higher intake of processed meat, higher intake of like sugar sweetened beverages. But even if someone may not be having, say, like obesity or some of the metabolic syndromes, you still may have higher exposure to, say, like unhealthy sort of diet. Another common factor that kind of connects all these is also the microplastics. There is actually studies that have actually shown that the microplastic exposures, like in like experimental models, do lead to like higher rates of growth of colon cancers. And there's also like synergism between high fat diet and microplastics, which have been demonstrated in experimental models. We do need more like epidemiological data, more tissue-based analysis to kind of really understand how that may be contributing. I do think that the studies, including ones that I've been involved in, do show differences in microbiome characteristics, both tissue-based microbiome as well as the stool microbiome characteristics in early onset versus average onset GI cancers. Now, some of it could be association with development to the relation to the development of cancer, but there are unique differences. And we have also identified that these microbiome differences do correlate with the metabolites in the body. So there is like a lot of connections between exposures, microbiome alterations, the metabolic changes in the body. What we are trying to do is we are also through the young ones that call it the cancer. Here we are prospectively collecting tissue, blood, stool from young onset patients, along with exposomal data, which is basically diet to exposures, physical activity, those things, and like really trying to integrate that to kind of understand how different factors may be interacting with each other, contributing to the development of cancer.
Part of the reason we're focusing on your great paper is that we don't have widespread awareness in the primary care and the urgent care clinics that young people can get cancers. Our screening is not established. We did drop it to 45 for colon, but we don't screen for cholangio. We don't screen for PANC. So we need to think about, is it enough of a problem that we need to begin shifting screening? So on one level, you're trying to figure out who's getting it and why, so we can intervene and reverse whatever it is that's causing it.
Mhm.
On the other end, from a public health perspective, we're trying to say, should we be looking more aggressively as a healthcare system at a time when our healthcare system is already stretched to the nines? But let's go one other place, and that is you're 42 years old, and now you've got stage 3 cancer. GI cancer, you have to work to pay for your insurance. It's disruptive because none of our treatments are easy. Talk a little bit about the impact of cancer for a 40-year-old versus what we all signed up for, which was a bunch of 70-year-olds.
Yeah, that's what makes like even more tougher, to manage. a lot of the people that you diagnosed with this cancer are at the stage where it's a growing family. They may have like recently married or have kids, or like, or like started a new job, gradually going up in terms of their career development when you're, facing this diagnosis. And then, so you also see that a lot of people, I mean, we don't, yeah, younger patients that I'm seeing, a lot of them do not have exposure to, healthcare, and having needed to go to the hospital back to back for biopsies, like chemotherapies, managing the complications and such. So all these things are new, which is then combined with other aspects in life, managing career and everything. So we do see higher, psychosocial distress. And
I'm glad to throw this in is that, 70-year-olds don't complain about any side effects, but 40-year-olds complain about every single side effect that we cause. It's always interesting to say, oh, yeah, you're young, you're tough, but they list them all. Whereas that 70-year-old's just used to feeling that way.
That's also something like, a part of our research is also trying to figure out, is there a biological mechanism that may be responsible for a higher risk of toxicity? But, it definitely impacts the ability to, the treatments, right? We do want to do intense treatments, but then, significant side effects, whether it's like nausea, vomiting, or even neuropathy from oxaliplatin. But then also thinking about long-term side effects for even, let's say, a curable colon cancer, where you have to receive adjuvant post-operative chemotherapy to decrease chance of it coming back. But then you are faced with, having to deal with some of these side effects. Or even like a post-surgical, like a low anterior rectal syndrome, like after a surgical resection for rectal cancer, could cause big impacts to the quality of life. So a lot of considerations there.
Part of it being the end of July is we got our brand new fellows coming in, and we're teaching them as much as we can. I think young people, for example, young patients, we want to be very aggressive is the language we use. But I keep trying to swing us away from that word to being more effective is really what we want. And this young group, I was thinking mostly around colorectal, but it's true in other diseases too, is increasing interest in organ preservation, avoiding radiation, the kinds of strategies we are using to, if you're going to have this problem and you're going to survive it for the next 30, 40 years, we want to optimize your quality of life. So I know your center does a lot of this. We do a lot of this. Less easy to do as a generalist or somebody out there who doesn't feel quite as comfortable. But I know we're all out there to help them and offer advice to try and optimize that patient's quality of life to be the most effective, not necessarily the most aggressive.
Yes, totally agree. Yeah, now with the prospect trial and the opera trials with in rectal cancer, we have like more evidence that we could, potentially avoid radiation, or portion of people avoid surgery altogether for rectal cancer. And I do think that, over time we would see increased adoption and of these approaches. There are also like studies looking at some early stage rectal cancers, whether we can, again, T1, T2 by using chemotherapy, chemoradiation, and avoid surgery in those subset of patients. There are newer immune checkpoint inhibitor combinations coming up. So whether they would translate into opportunities for non-operative management in microsatellite unstable tumors. Can we develop effective immunotherapies for microsatellite stable rectal cancers that can also help avoid risks of some of these other modalities of treatment?
Thejas, I can't thank you enough for taking the time. I know you're busy. I know we're all busy, but this is such an important topic. And your paper got the appropriate big national recognition on news channels and the like. And I just wanted to make sure that our audience also had a little bit deeper dive on this issue, because we're the ones that are going to be meeting these people across the exam room table from us. And we want you to know out there as much as we know, so that we can make it a little easier on all those folks out there. Thank you very much. And for Oncology Unscripted, this is John Marshall. Thanks for joining.